All right. All good. Yes.
Right. And it should be better now. So I was saying that we received 65 cases. We chose the top 17, but because keeping it to 15 was really hard. We appreciate everyone's hard work in showing us their cases. And it is really exciting because I think the idea is to engage. We are taking advantage of this renewed interest in virtual meetings, and we took advantage of the bad that came with the pandemic to invite our colleagues from elsewhere and share their best cases with us. And we also want to thank, I want to thank Farouk because he was the one that found the funding. So because, I mean, it would be nice, and it's gonna be nice for all of us to get here together and show our best cases. However, it's even better that the best case is gonna get $1,000. I mean, that makes it.
That's definitely an extra incentive. On top of the fact that the best case is also going to get published in Applied Radiology. And I think it really just encourages people to write up. We already got messages from some of the folks from last year telling us that they actually went ahead and published some of the cases that they sent to us. So I think this is really just creating a network of trainees from around the world, encouraging them to continue to pursue their academic dreams and their academic careers and just support one another. So we're excited to get the show on the road. Let's go ahead
Yeah.
and do that.
Yep. So I guess that if we're gonna just go ahead and introduce to our host for the
Yes.
day,
Yes.
that is gonna be our newest interventional radiology attending, our newest faculty member here at the Children's Hospital of Philadelphia and at the University of Pennsylvania. Is Stephanie Cajigas Loyola. Is going to host today, and I just want to say that she was a fantastic diagnostic radiology fellow. She's also a fantastic interventional radiology fellow, and we invited her in part because she does have that charisma with
Yes.
people, and
Yes.
that
Yes.
like for education and for teaching.
Yes.
So she helped us not only collecting the cases, but also helping people develop their PowerPoints and their videos. So anyway, I think it was an obvious choice. And also because she was one of the few in our department that can pronounce all the last names in the proper way. So without further ado, here is Stephanie.
Hi, everybody. As Dr. Otero said, I'm Stephanie, and I'm going to be your host today. So we're just going to get ahead and get started with our keynote speaker, Doctora Zavala Travers. She is a pediatric radiologist at the Hospital Pediátrico Pereira Rosell at the Universidad de la República de Montevideo, Uruguay. She is an expert in 3D printing, advanced biomodeling, as well as the co-founder of a new center for clinical innovation in pediatric imaging at her hospital. However, her passion for pushing our specialty forward long predates this latest success story that we'll hear today. For 2 years, she was a research fellow at the Division of Imaging, Diagnostics, and Software Reliability of the Food and Drug Administration, where they study the effect of color display on diagnostic performance and other advanced science awesome stuff. Así que sin más, aquí los dejo con la doctora Silvina Zavala. If anyone has any questions, feel free to put them in the comments, and we'll go over them after her presentation. Dr. Zavala, you're free to share your screen.
Hello and welcome everybody to the global case competition today. Thank you, Stephanie, for the kind introduction, and thank you, Hansel and Farouk, for organizing all of this. I think it's great that we all see each other and share our cases. I think we are going to learn a lot today. So, okay, let me share my screen. Okay, I hope you see everything there. Perfect. So as Stephanie was saying, right now I am dedicating a lot of my time to 3D modeling and 3D printing and virtual surgical planning. And my idea today is to show you a little bit what we do and to encourage all those innovative radiologists that are connected today to start their own lab where they are. And I hope you see it's not that hard and that you just need energy and time and you can do it wherever you are. Okay, so I would like to start with this image. This is CT of a 16-year-old girl. She was being studied for neurofibromas. Since most of us here are radiologists today, I think you already saw that something's going on here and here. And so she had this malignant neurofibroma, and surgeons were studying her because they wanted, since she was starting to have like bad symptoms and signs, they were going to remove this fibroma. So as you can see, for us, it may be easy to realize that here there's a vessel and the lesion borders are here. Here is not that easy to see. Looks like it's going out of the thorax. And here it's kind of difficult to see what's muscle and what's lesion. But how about I'll show you this other image. Now it appears easier, right? To see where the lesion is, where vessels are, where bones are. And if we go a step further and I show you this, I'm sure we all prefer to see this kind of image to study a patient and to see where a lesion is, what the relationship with vessels is. And even better, if we can show, oops, sorry, this, I wanted to show you a video there. Let's see if it goes, okay. So how about we go one step further and we can look at these images in this way, just showing selectively what we want, if we want vessels, veins, arteries, if we want to study relationship of this lesion with bone, and if we can rotate all these. And you can imagine that maybe for us, we are kind of used to making these images in our head. As soon as we see a CT, this kind of 3D images just create for us. But for surgeons who are not specifically trained on DICOM images, 2D images, these kind of images transfer information much faster for them. And it's also easier for them to talk to each other and to decide what treatment is best, if it's best to remove the first rib, to board this patient, and all these kind of little details for surgery. So these are 3D biomodels. Okay, we can define them as 3-dimensional images, which are representation of part of the human body with the aim of studying a disease, planning treatment, or assessing therapy response. And this might sound familiar to you because it's the same definition we use for medical imaging. Medical images are any body image, and here I'm copying the FDA definition of medical imaging, which are several different technologies that are used to view human body in order to diagnose, monitor, or treat medical conditions. And who, if not us, are the best to interpret and to process and to decide on medical images? So that's why I decided today to show you all what we have done here and to try to, in a way, encourage you to learn and to participate in these technologies so we can do safe practices, okay? So we play a huge role in the implementation of this new technology to the hospital. So this is a little bit of what we are going to see today. What are 3D biomodels in diagnostics, in treatment? What's virtual surgical planning, applications and benefits? And then I'm gonna talk a little bit about our role and how to start a 3D lab in your hospital today, okay? So as we were seeing, this is the same case. This is a much easier way to understand patient imaging findings. We are not adding new information. All this information is in the CT or in the MRI. We are just presenting information in a different way. And what this allows us is sometimes to combine information, because we can put together in the same biomodel information that comes from CT, from MRI, and also from any other volumetric study. This, for example, combines MRI, PET, and CT. All of this to create this biomodel, which also has the information of the area of the lesion that is has the most uptake in the PET CT. So combining information. Also, we can do more information a long time. So this is the same case I was showing you before, but this was a lesion before the first surgery. So we have the information of what was going on there. This is a recurrence. Unfortunately, this girl has had this Ewing sarcoma on her pelvis, and this was a recurrence. And this is how the bone is after the surgery. And this in gray, light gray, is the part of the bone that we need to remove because it's the part that is affected by the bone. So all this information, if we look at the CT, we have it there. But again, looking at biomodels in 3D, in colors, makes it much easier. Also, these technologies allows us to go a little bit further with the information that we can get from these studies. For example, we can get volumetric estimates. This image we are looking at here is also a Ewing sarcoma of a femur. And the red lesion is a lesion pre-chemotherapy. The white lesion is a lesion post-chemotherapy. And we can already see that there's a great response, but we can also estimate how much in volume this lesion shrinks. This is good for pre-post therapy assessment, but also sometimes for surgical indications, because, for example, consider a liver and metastasis in the liver. Sometimes metastasis can be removed, but we want to know how much liver is going to be there after we remove metastasis. So this is also a good tool for that. We can use this for prognostic value. All these patients with COVID in these last years, unfortunately, it's years already now. So we can see how much of the lung is affected. And this affection, this volumetric affection, has been linked to prognostic in terms of function of the lung. Also, we can follow up lesions. There are some lesions that we don't do surgery on, like fibromatosis, for example, and we can do follow-up with volumetric or transplant decisions. And this is great because so far we saw 3D models in diagnostic. Now this is 3D models in treatment. So here we have, for example, one patient with osteosarcoma in the tibia. You can see here the biomodel lesion in red. This is a great tool that can look at transparencies, so we see better the margins. If you pay attention here, there's a halo, like a transparent halo. This is the simulation of the oncological margins, 10 millimeters margin. And from that information, we can plan where we want to cut in order to save as much bone, as much healthy bone as possible, and to remove safely all tumor. So we can design these tools. These tools are called surgical guides, which are then 3D printed, as you can see below. These are 3D printed in resins. And we also 3D print the bones and the osteotomies of the bones. So during surgery, as you see here, we can use a guide to cut the bone and then double check that we cut where we wanted, where we planned. Here is the X-ray during surgery. You see that it reproduces exactly what we planned virtually. And for us, this is very important because our surgical groups use a technique, which is to, they froze the bone in nitrogen. So this same bone, after it is frozen, it's supposed to not have cancer anymore. And so it's used to reconstruct the girl's bone. This was a boy, sorry. So we don't get the piece for pathology study. We need to trust that we removed and we cut and we froze everything that had bone. So this is like a double check that we are doing right. So as you can see, this is a very complex step-by-step surgical procedure. And this allows us to be sure that we precisely cut where we were supposed to cut. So makes surgeries more precise. Also, major decisions are taken outside the OR. So this makes the surgery faster and also safer for the patients because surgeons now know all the anatomy in detail, so they can avoid making lesions accidentally in the bone or in the vessels and everything. In the end, this results in less X-ray also for the surgical team because they will need less fluoroscopy time. Patients bleed less, so it's more safe for them in that sense too. And if you put everything into consideration, there are many studies that say that we save money. So this is a concern sometimes because these technologies, we have to invest a little bit in technology or in human resources, but many studies have now confirmed that in the end, because of all these benefits in surgery, it ends up saving money. So this is another case of virtual surgical planning. As you can see, we can use the mirror image of the healthy part of the face. This was a patient that had a motorbike accident, and as you can see, he had a huge fracture. With the mirror of the healthy face, we can reconstruct the head and part of the face bone. We then print the reconstructed version. You see it here. This is in PLA. And the plastic surgeons use this 3D printed piece to pre-mold all these plates that then they use during the surgery to reconstruct the face. So this is the final result after surgery. You can see that it's pretty good and it's similar to what we planned virtually. Another thing that this technology allows us is to make parts of the body custom made. So they are the same size that the original part was in titanium. And there are now technologies that allows us to have these kinds of implants that are kind of elastic, that move with the thorax, or bones like these that are trabeculated titanium that are very similar to the original bone and allow the cells from the healthy bone surrounding this implant to migrate to the implant. So results are much better because of size and also because of the kind of material that we are using. And this is the last thing that we are doing now. This was a surgery from yesterday and I'm super happy because it went really, really good. We had this girl that had this osteosarcoma in the femur. So for this surgery, we were going to use, it's the first time in Uruguay actually that we use bone from donors, but that the whole bone. So we can get the fragment of the bone because so far we used it like a powder just to to fix holes or that kind of things, but not the bone fragment. So for this girl, we planned the surgery, as I showed you before, with the margins, with safe margins. All you see in colors are osteotomies. And then we had all the bones that we had in the donor banks undergo CT, and we did the biomodel for all the femurs that we had available. And this was great because this allowed us to match size. So we matched the size of the bone of the girl with all the other femurs, and we got the one, which is the one you see in blue, that had the most similar size to the bone of the girl, which is the one you see in gray here. So this is how it was supposed to end up, the fragment. For this to happen, we designed surgical guides, one for her bone. So we decided what fragment to remove. And here you see her bone after we had removed this piece. So it looks exactly as what we had planned. And we did the same for the donor bone. We had the same guide with the same cutting osteotomy planes. And here you see the donor bone, the fragment that we were going to use on her. And this is the final result, and it looked great. And it's so good to see that we can help in this way. So these reconstructions that look so similar to her original bone makes it a lot more probable that her results are good after surgery. So not only we are sure that in terms of oncologic results, we removed everything, but we are also making sure that her reconstructive results are the best we can do for her. So as you see, we can apply, I'm not going to talk about all of these cases because this would be too long, but we have done cases on plastic surgery, hand surgery, spine surgery. We do pediatric surgery, these orthopedics, as we were talking about right now, cardiac surgery, thoracic surgery, maxillofacial, neurosurgery. So this means that any area of your interest in radiology, you can dedicate a little bit to make this technology thrive because it's very, very useful for patients. And not only for the clinical side, but also for communicating to patients. In these cases, I was telling you about the surgeon used all these biomodels to explain the girl what the procedure was. And this helps reduce their anxiety because they understand what's going to happen, and also to understand the risks and what it means for the patient and her family in the surgery. So what are 3D teams? And this is important because if one of these is not on board, it might not go well. So this is teamwork, okay? We need clinicians because they know what they want, what they need for their patients. We radiologists are very important for all the processing and creating of the biomodel. And then engineers do their great part on guide design and all the other engineers part. Why are we so important? So here are just a few of the reasons. First, for each biomodel, there's imaging modality that works best. For example, for bones, we know, so I'm gonna go a little back. Most of these biomodels depend on the contrast we have with the interest, the structure interest, and the surrounding structures. So we want the structure to be highlighted. So bones will be best obtained from CTs, and soft tissue will be best obtained from MRI. And the series of MRI, the sequence, will depend on what disease has the patient and who is going to make that decision. That's radiologists, because we are going to be there and we are going to say, okay, this with contrast highlights better this lesion or this lesion, or this other vascular lesion is better on this other. We want to reduce artifacts. As you can see here, artifacts degrade not only diagnostics, because it's almost impossible to say what's going on here. This was spine of scoliotic girl. But after we run this metal artifact software removing softwares, you see it's much better, not only for diagnostics, but also the quality of the biomodels is much better, because now you can really see what's going on and it's not this mass something. So we know when for diagnostics is good, and also the same rules apply for biomodels. We can say what sequence we need, what contrast agent if we need or not. So almost the same things that we do for diagnostics, we are going to do for thinking if this girl or this boy or this lady maybe needs a biomodel. We want to be ready with the images we get to we want to have them ready in case they need biomodeling, okay? So also, this is an important thing here I want you to take with you. We don't need special images to get biomodels. That's to say, they are obtained from the same CT or MRI that the patient is getting for diagnosis. But we need these things. So we need the study to be acquired in volumetrically. Most of the CTs now are, but sometimes we don't have that technology. And this is especially important for MRI, because not all of the sequences are acquired volumetrically, so we have to plan ahead. And we are going to decide as radiologists, because they take time and it's extra time for the patient and for the study, which sequence is going to take to be acquired volumetrically. Then we need to reprocess isovoxel. Okay, so the thin section has to be equal size or less size than the pixel. Okay, that's very important in order to get quality biomodels. These are other two things that make it important that radiologists are part of the team. So when we combine information from CT and MRI, there's a part of this process that needs to fuse images and to overlay one to the other. And if we get it wrong, then remember that we are going to, for example, for this case, we're going to get the lesion. This orange part is from the MRI, and this yellow part is from the CT. So if overlaying is not correct, then the location and the relation of location in the biomodel will not be correct. So this step has to be perfect. Also segmentation, which is this, what you're seeing here, the painting in colors, it's called segmentation, needs to be done or strictly supervised with the radiologist. Some things are made automatically. So for example, bones, we just press a button, and at least maybe you will have to double check that it went well, but it's mostly automatic. But then other things are not. So for example, lesions have to be painted mostly manually, and we have to decide where the borders are. And if you remember from earlier, this decision of saying that the lesion gets here, it's very important, because after that we are going to do simulation of the margins. And with that, we are going to tell the surgeon where to cut. So in a way, you are deciding where you're going to cut during surgery and what is the fragment you're going to remove. So there's a lot of medical responsibility here, and that's why it's so important that radiologists supervise that these borders are correct. Also, after that, biomodeling tools can, in order to make this smoother, You see here we have this rib mark here. If we use or misuse the smoothing tools, we can lose information and then the biomodels loses fidelity. Okay, so all this was to tell you that software tools are still semi-automatics, and we as radiologists need to ensure that biomodels are precise to the patient to ensure that the process will be safe. Now, what can we do? So as you can see, I've gone through a long path. I started in 2019 with this lab here in Uruguay, and I'm happy because we have done a lot since we began. And that's why I want to encourage people to start their lab, because when I started, I didn't have anything. I just wanted to dedicate my time to this because I really like that. We did a survey because I said, okay, if this is such a great technology, why is it not so available for most countries? And because that's what I sensed talking to colleagues. So we did this survey with a surgeon from Spain to learn a little bit about Latin America and Spain and Portugal. So that was an Ibero-American survey to see what was happening. Why was it so difficult for countries in Ibero-America to implement this technology? And what we learned was this. So one of the most named reasons was lack of knowledge on 3D technology benefits. So most of them didn't know that this technology existed, and so they didn't use it. Or also surgeons or their clinicians, they didn't know they could use or what they could obtain, so that's why they couldn't use it. And obviously lack of funds, lack of human resources, lack of software and hardware. So in the next few slides, I'm gonna show you a little workaround around all these difficulties. So we are gonna talk about these 4 things. First, trainings. Okay, here are 2 courses that were the ones that I did. They are aimed at radiologists and clinicians, so they are very good. Both of them are from Spain. I'm sure there are many other courses. You just have to look to search. But these 2, which are the ones that I did, are the ones I know, and they are very good for our training as radiologists. Also, you have software tutorials. Now I'm going to show you the softwares, and with the software come tutorials. They are free and you can use them to train yourself. And the most important thing is to practice. Okay, so now I'm going to show you free software tools. So that's why here you say practice, because the only thing you need here, apart from enthusiasm, is time, because that's the way to get there. Also, as I was telling you, most of our colleagues, surgeons and maxillofacial and orthopedics, they don't know about the existence of these technologies and the benefits, or maybe they heard about that on a conference, but they don't know that's a possibility in their countries, which was our situation when we wanted to start. So we went to each of their rounds, and we went to orthopedics and prepared like a presentation telling them benefits applied specifically to their specialty. And we went to neuro and to pediatric surgery and to show them specifically. And then they started working with us. It's very important to work together with colleagues because they are the ones with patients and they are the ones that are going to use the technology. So they have to be on board. But I'm telling you, they get excited very fast. So if you show them a little bit of what you can do with the technology, they are immediately on board. These are the softwares I was telling you about. So all these softwares I'm gonna do a disclaimer here. Nobody is paying for this talk. I'm just giving you tools because I think this is important to learn, okay? So all these, the software I'm gonna name here are free to download, and all of them have tutorials which you can use to learn, okay? So these are 3 segmentation software. Segmentation software is the one that allows you to go from the DICOM image to the 3D image, okay? Most of them work very similarly. You just have to learn the basics and then you can use any of them. Maybe start with this one, which is the most complete, and it's developed by the NIH. So it's great and has a lot of documentation and tutorials that you can use. The biomodeling software I use to design the guides, which obviously has to be your second step. So first, just try to do bones, for example, are a good thing to start because they are easy to segment and you can very easily go from this segmentation to a 3D print, and getting your goals will help you go forward. But if you're already on this stage, you can use biomodeling software. This is Mesh Mixer. I'm sorry, I forgot to put here the name, Mesh Mixer. You can download it for free. And this is 3D viewer of this kind of data. These are STLs data, the 3D ones. The files are STLs. These are softwares you can use to print. Okay, so Cura is the one that we most of us use to 3D print, because after you prepare this 3D file, you have to prepare it to print. So this is 3D printing software. If you are trying resins, you can use these two. Okay, so these two are for resins. These two are to PLA, the kind of bones. This is the most common one. So you can start here. For example, this is PLA print. Okay, for this, you just need one of the segmentation. And then after you have your STL, you can go directly to Cura and to prepare to print. Okay. Now, you know that you can get software for free. Remember, we are all radiologists here, but remember that it is very important to be supervised, okay? Because there are lots of biomedical engineers that are trying to also bring their knowledge to this area. And it's very important that they feel supported by us and that we help them on these very important things that I was talking before. How can you get your printer? Okay, first thing, you don't need a 3D printer to start biomodeling, okay? Because that's our experience. For pediatric surgery, for example, most of them just use the 3D models, the virtual 3D models. For example, the first case I show you about the neurofibroma, we didn't print anything there. They just use a 3D biomodel and use it to virtual plan and to learn about anatomy. And we don't need to print anything. So if you don't have a printer, don't get sad. You can still start and learn about software. Second, if you want to print or need to print, first, you can consider donations. That's how we got our 3D printer. This 3D printer was in a company, they were not using it, and I just asked for it, and they say, okay, we can give it to you. So just ask. Sometimes foundations with people that have undergone diseases that needed this kind of technology are also happy to collaborate. Consider collaborations with university or with industry. Sometimes they are happy to collaborate with hospitals on this technology. And for them, if they have the printers for other things, it's very easy to just print whatever you need and give it to you. And maybe it's easier to get to a 3D printer even if it's not your own, to get your 3D print ready. And right now it's not that expensive. Before it was like several $1,000s to get a 3D printer. Now we have desktop 3D printers that you can get for maybe $300. And this is not very expensive for a hospital. And there are lots of publications that say that the difference between the results of these printers and the industrial printer are negligible in terms of what we need here. Remember, this is teamwork, okay? We need radiologists. So how can we get hospitals to pay us to dedicate to this? You can consider a new position, but this is going to take more time. So you can talk to your supervisor and ask for some hours dedication, maybe 1 or 2 hours a week until you learn. And it's going to be a process. The more you see this helps and the clinicians need you and come ask for your help, the more hours they're going to give you, and then they're going to consider a new position, because that was the case for us. Okay, we started some hours of dedication. Now there are 2 positions that we are trying to they are there. We are just getting our positions up as 3D specialists. For bioengineers, it's the same. Consider university collaborations. We didn't have a bioengineer, but we went and knocked at the door at the industry, from architecture, so design, oh, I cannot think of the word. So this area of engineering that they design things, and they had 3D printers, and they were very happy to collaborate with us. And they were eager to collaborate with hospitals because it meant something for them. And also we participated in joint grants together with them. So just talk to other universities or areas where they have bioengineers, and I'm sure you're going to get some collaborations. And don't forget about clinicians, because sometimes they are the most interested in getting this technology, and they can help you get either positions or software or hardware or money or anything, okay? And if you don't have, remember that this is a great thing about this technology. We can do it from another country or another hospital, or maybe you can do a part in your hospital and then another part can be done in another area. Or you can do this on your main city or main hospital, but you can still send all this information to a little hospital, maybe in an area where you cannot get this specialized radiology. Don't hesitate to ask for help. And this is very important because this is our path. So I trained at the St. John de Déu Hospital in Barcelona, at their 3D printed unit with Marta, which is engineer, and she spent hours sitting with me, or the other way around, probably. They helped us a lot to create our 3D area at the hospital. And us, in our turn, helped Peru. And I'm sure Carlos Uvas is connected right now. This is his 3D printing lab. And they very quickly were able to print pieces. And now, in their turn, they are helping Ecuador. And there's a resident there, which is also learning to 3D print and to biomodel. And we have at SLARP, we created this new technologies working group in the Latin American Society of Pediatric Radiology. And we are very happy to receive any questions you have and to help you to start your lab. So this is a little bit of us. These are Dr. Juan Sattler and Jose Perdomo. This is Andres Garcia Baise, our director. And this is the engineer I was talking you about, that he's Nicolas Rux. He was working, he's from another university, and he was just collaborating with us to start. We started with only one printer that was donated to us. Then the next year, that's last year, we got all the surgeons to collaborate between departments and to buy these 2, which are resin printers. And we got 3 more interested here, which are Drs. Tabaré Lizondo, Vanessa Riaño, and then Pierre Pomarac, who is radiographer, interested in participating in our group. And we have done a lot of stuff, many cases we have helped with. And you don't need much. And I like this photo because I was moving my stuff from one place to the next, because very soon we are going to be moved to this new area. We got this new area here. All my stuff fits in this cart. So these 2 printers and my PLA printer. Everything fits in a little cart. So that's everything I need because I need my computer. And so you don't need much. You don't need much space. Just with a little room, you can do everything, okay? And for me, this is one of the most important slides, and it's my last. Don't be discouraged when things go wrong, because they will go wrong, okay? And this is my collection, a part of my collection of things that have gone wrong and that had made me very anxious and very sad and very stressed. Coming to your 3D printer and seeing this instead of your finished piece is not good. And you see here that these and these are the same bone. And the first time we printed it, supports were not good designed. So you can see we had made everything here, everything possible with low gun, with everything to try to maintain the structure, but it was obvious that it was not going to be well. But we learned from this. And next time we put it different, look at the supports, and the piece was perfect. And here we have so many things. So accidental power cuts. I unplugged my printer without realizing that that plug was a printer. So for everything that happened, we learned a lot, okay? And this is important. Take those opportunities of things that went wrong to learn what not to repeat. So I hope this was helpful for you. Remember, I'm here. If you need help, I'm here to help you. I'm happy to get your questions. And I know I'm very past time. I'm sorry, Hansel and everybody else. But this is all. So this is what I want to leave you with. 3D models are a new kind of medical image, and that is an important word because that's why we are so important here. And you can start your lab today, okay? Don't hesitate for help. Here are my contact information. Here's my contact information, and just get in touch. We are happy to help you.
Thank you so much, Dr. Zavala, for this excellent talk. I think everybody was riddled up about it. There's a few questions in the Q&A, and there's some comments in the chat. Just to put the agenda, if you don't mind answering those directly in the chat, that would be great. I think you covered most of them anyway as the presentation came along, but just so the people can get clarification. Thank you so much.
Thank you for the invitation. I'm very happy. I'm happy to answer every question, and if not, I'm gonna leave my.
Alrighty, so we're gonna go ahead and continue with the selected case presentations and their recorded videos. Our first recorded video presenter is Doctora Liz Arela Quipse, representando a Peru, with her presentation titled Spinal Trauma with Congenital Anomaly. And we're gonna start sharing now.
Good morning, good afternoon, or everyone. The National Institute of Childhood wants to present this case entitled Spinal Trauma in a Child with Congenital Anomaly of C1. My name is Liz Arela Quipse, and Juan Pablo Sánchez Navarro is my mentor. The spinal trauma in children below 5 years old is less than 1%, and there is an inverse correlation between age and severity. You can find permanent neurologic damage in around 60% of this population, and the other thing you have to keep in mind is the non-accidental trauma with that you can find in around 19%, mainly in the population between 0 to 2 years. So the prevalence of congenital C1 are 5%. And if you are talking about on the posterior part of the C1, they represent around 81% of the cases. Our patient, it was a little boy aged 1 year with 9 from the northern highlands of Peru. He had a fall. After that, he lost the strength and the sensory of the right side of the body. And while he was brought to a local hospital, after that, he was referred to our institute. In our institute, a CT scanner of the head and neck part of the patient was performed. We can find a prominence which is formed with the hypoplastic posterior part of the C1 and the right side of the occipital bone. All this bony prominence is narrowing the spinal space at level of C1. In the MRI imaging, you can find increase in the signal inside the spinal cord. You can see cystic changes inside the spinal cord, and you can see like how is expressing the spinal cord. You can find edema inside the spinal cord in this coronal image. After that, the service of the institute as for two aspects to printing a model of the evaluation in order to explain the parents and in order to evaluate the better access to the osteotomy in order to free the spinal cord. And so after the surgery, the patient evolution was good, and she was in the circulatory of the right side of the body with a persistent decrease in the strength of the right. He continues with the physical therapy nowadays, and we can find in this picture our findings. We have a classic posterior part of the C1 with this joint with the right side of the occipital bone, and changes related with osteotomy after the surgery. We can the opportunity to find this patient with another hypoplastic posterior part of the atlas with fusion to the occipital base, and we have to use in order to print the 3D model through different programs, 3D slicers to select the areas to print. In this case, only the bone structures of the cervical spinal patient. Next mixer, mesh mixer. This program helps us to get out all the areas we don't need to print. And finally, the specific program in order to put some parameters for the printer. After that, the printer gives us how much time the printer needs to finish the work and how much material do we need to invest. After the 11 years of work, the model was printed and invest around 55 grams of the product. And our conclusions, the tomography reconstruction and 3D printing in real size have contributed to an accurate diagnosis, surgical planning, and explanation to parents. Parents in this case of underlying cervical canal C1 level, exacerbated by trauma in a pediatric patient occurred from allowing his recovery and thank you so much from the institute and the research and thank you so much.
Okay. Okay, everybody. Sorry, give me a moment. Sorry about that. We're getting some feedback. Let me. I think that should be better. Before I present our next speaker, I just want to remind you guys that there will be a poll that will be opening up after the first session for you guys to vote which presentation you liked, which presentations you thought was the most interesting. As the person who receives most votes, will get a prize. So just keep that in mind as you see as you listen to all these fabulous presentations. And once the poll is open, we'll put it in the group chat and we'll give you more instructions then. Our next presenter is Doctora Agustina Sabatella, representando Argentina with her titled Case Myocarditis from Dengue Fever.
Hello, everybody. I'm Agustina Sabatella, speaking from Buenos Aires, Argentina. I'm currently at my second year of residency at the German Hospital of Buenos Aires. And with my fellow colleague Enzo Casali, we prepared this case of myocarditis from dengue fever, and we'd like you to show you its MRI findings. A 70-year-old male patient with a history of hypertension and recent dengue infection presented to the emergency department with dyspnea, asthenia, and chest pain of 1 month duration. He referred no history of coronary artery disease. His blood test revealed an increasement in transaminases, as well as neutropenia and low platelets, and a high sensitivity T-troponin of 131. The EKG showed sinus bradycardia and normal ST segment. An echocardiogram and cardiac MRI were also acquired. The echocardiogram showed normal function and diameters, no valvulopathy and pericardial effusion. The cardiac MRI did show some relevant findings. Firstly, we saw an asynchronous movement of the interventricular septum with subtle septum hypertrophy. Also, the left ventricular systolic functions was slightly decreased with an ejection fraction of 52%. There were no pericardial effusion or alterations. The mid region of the septum presented with increased T2 signal, intramural myocardial enhancement, and increased T1 signal and T1 mapping. The image on the right is a short axis T2 sequence that shows an increased signal intensity at the mid region of the interventricular septum compared to the pectoral muscle. This could be a sign of edema that would prompt us to think about myocarditis. The difference between both regions must be at least double to be relevant. In this image, there are delayed enhancement, 4 chambers, and short axis views, respectively, that show linear intramyocardial septal enhancement that we can see here with the red arrows. These are native T1 mapping and post-gadolinium mapping images that show T1 fold time values increase. They both evidence the presence of myocardial edema at septal level. Here. These are multi-slice short axis cine images from base to apex, showing slight decline in left ventricular function with an ejection fraction of 82%. Considering his clinical history, current symptoms, elevation of cardiac markers, and the MRI results, the diagnosis of dengue myocarditis was confirmed. Symptomatic treatment was indicated with a favorable evolution. Endemic dengue fever infection represents a major challenge for Latin America. In 2020, Argentina experienced the worst outbreak of dengue in its history, and the incidence is projected to increase. There is a lack of scientific data regarding its cardiovascular effects, treatment, and prognosis. Lack of data and low clinical suspicion results in highly underdiagnosed cardiac compromise. The clinical data, cardiac biomarkers, and cardiac MRI are extremely valuable for a prompt and correct diagnosis. Dengue fever infection is increasing and cardiac involvement is underdiagnosed. Difficulty in diagnosing myocarditis is based on the lack of specificity and sensitivity of the different diagnosis techniques. Cardiac MRI is proposed as a useful tool for diagnosis and prognosis of dengue myocarditis. Thank you all very much for listening. See you next time.
Okay. Our next speaker is going to be Doctora Débora Otto, representando a Brazil with her presentation titled Renal Tuberculosis.
My name is Débora. I'm from Brazil and the current fellow of the Pediatric Radiology Program in the Instituto da Criança do Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo. We are going to present a case of tuberculosis in a kidney transplant recipient attended in our service. The patient was a 12-year-old boy with a history of chronic renal disease secondary to posterior urethral valve. He had no other comorbidities, and the initial tuberculin test was negative. He was then submitted to a renal transplant in May 2021. The deceased donor was a 15-year-old girl who had died of a subarachnoid hemorrhage. The second kidney of the same girl was donated to another child, a 6-year-old boy, also followed in our service. This information is important, and we are going to talk about this child again later in this presentation. Well, the patient had a good outcome in the first week post-procedure, and this is the ultrasound done in the first day post-transplant that showed good perfusion of the entire kidney and a homogeneous aspect of the parenchyma. However, 2 weeks post-surgery, he started a progressive decline in the renal function, and the ultrasound was then repeated. And these are the images of the exam, which showed the new hypoechoic area in the interpolar region, suggestive of ischemic lesion. The ischemic lesion was posteriorly confirmed by a contrast-enhanced ultrasound, which showed an additional area of decreased perfusion in the upper pole. The nephrology team proceeded with the biopsy of the graft with the histological results of acute tubular necrosis. In the face of this diagnosis, it was started post-therapy. However, a month later, the patient was again admitted in our hospital with persistent episodes of fever and increase of the creatinine levels. The initial urine tests were negative. The child was submitted to a new ultrasound showing multiple heterogeneous avascular complex foci compatible with abscesses. Well, returning to the beginning of the presentation, as you must recall, the other kidney of the deceased donor was given to a 6-year-old boy, also a patient in the same hospital. This second recipient started to develop abdominal pain and fever a month after the transplant. And as you can see in this ultrasound, the kidney had multiple hypoechogenic foci compatible with microabscesses. The gastric lavage and urine tests of this patient were positive for tuberculosis. And since the patient didn't have contact with bacilliferous adults, an infection coming from the donor was considered. Well, with these informations and back to our first patient, it was decided to investigate the possibility that the abscesses were caused by a tuberculosis infection. The new biopsy of the kidney, as well as bacilloscopy of urine samples, were positive for tuberculosis. The specific treatment was started, but it wasn't possible to preserve the graft, so the kidney had to be removed a few weeks later. Well, we chose to present this particular case for two reasons. The first is the percent number of pediatric renal transplants in our country. According to the Brazilian Organ Transplantation Society, more than 300 renal transplants are performed in children each year. And the second reason is the fact that tuberculosis still represents in Brazil an important cause of mortality and morbidity among immunosuppressed patients. The overall incidence of tuberculosis in renal transplant recipients is estimated to be 20 to 74 times that of the general population. So to avoid this complication, the World Health Organization recommends testing for latent TB in patients preparing for solid organ transplant. Also, active TB infection should be ruled out by a chest X-ray. The leading donors in its turn should undergo PPD skin testing. But the situation is more complex in cadaveric donor, which was the case of the patient we just presented, because there is often not enough information to rule out the existence of latent TB infection or active TB. This is why it's extremely important that the donor goes through a thorough study, especially for TB. And even if there isn't proof of an active TB, if there is a well-founded suspicion, it should also contraindicate the transplant. Ideally, biopsy samples should be obtained and cultures must be performed at the time of transplantation to rule out active TB in the donor. But a close follow-up of the patient in the post-transplant period is also essential to detect renal failure or infectious symptoms at an early stage, so the treatment can be the most effective possible and the donated organ can be preserved. So, this is the bibliography, and we'd like to thank you all for giving us the opportunity to present this case.
Thank you, Dr. Otto, for this presentation. Now we are going to continue with Dr. Enzo Silvera, representando Uruguay, with his case of amyloidosis.
Hello everyone, I'm Dr. Enzo Silvera from Uruguay. This is a case report of systemic amyloidosis with large bowel involvement. Our patient is a 60 years old male with worsening of exertional dyspnea, peripheral edema, abdominal distension and nocturia. He was also tachycardic. Electrocardiogram showed atrial flutter, troponin were negative and pro-BNP levels were high. Echocardiogram showed left ventricle wall thickening, dilated left and right atrium, diastolic restrictive dysfunction, globally reduced longitudinal strain. The left ventricle ejection fraction was preserved with 60% and mild pericardial effusion. This finding led to the suspicion of cardiac amyloidosis. Our patient, after 7 days of admissions, suffers from hematochexia, left flank abdominal pain, and leukocytosis. CT was requested to exclude acute diverticular disease. Post-contrast oblique abdominal pelvic CT shows segmentary circumferential and symmetric large bowel wall thickening on the transverse and descending colon with an extension of 25 centimeters. A stratified pattern of attenuation was documented with a mucosal enhancement with mild pericolic fat stranding. The remaining colon layers were isodense and absence of lymphadenopathies or any signs of diverticular disease. These findings led to diagnosis of inflammatory or infectious colitis. Endoscopy documented loss of vascular pattern, edema, erythema, and superficial fibrin ulcers in the transverse and descending colon. Congo red staining of colon biopsy specimens reveals apple green birefringence under polarized light, which confirm the diagnosis of intestinal amyloidosis and mild inflammatory colitis. Cardiac and magnetic resonance revealed a myocardial low to intermediate signal on T1 and T2 images, and a high signal on phase-sensitive impression recovery sequence related to a diffuse amyloid deposit. PYP showed no uptake of radiotracer in the myocardium. Perugini score was 1, and heart contralateral ratio was 1.39, which excluded transthyretin amyloidosis and guided the diagnosis to light chain hemoglobin amyloidosis. As you can see on the SPECT-CT images on axial and coronal slices, there are no uptake of PYP in the myocardium. Bone marrow biopsy with 15% kappa clonal plasma cells confirmed the diagnosis of AL due to plasma cells discretion. Hemogram, renal function, calcemia, and low-dose CT, whole body CT were all normal. 3 light chain kappa levels were high, and lambda normal. Salivary glands and abdominal fat biopsy confirmed amyloid deposits. Our patient started chemotherapy and improved. An autologous stem cell transplant was put into consideration as the next step for treatment. Amyloidosis is a heterogeneous group of diseases characterized by the extracellular deposition of a misfolded protein resistant to proteolysis called amyloid. There are more than 30 amyloid precursor proteins. The main types are light chain immunoglobulins, transthyretin, serum protein A, beta-2 microglobulin, apolipoprotein E. Amyloidosis can affect a single or a multiple organs as a systemic disease. Extracellular amyloid depositions affects the structure and the function of these organs. Intestinal amyloidosis is a rare clinical representation of AL. Less than 6% of the patients with AL are symptomatic. Intestinal amyloidosis originates from plasma cell dyscrasia, multiple myeloma, or chronic inflammatory state. The clinical manifestation of intestinal amyloidosis are non-specific, with weight loss, abdominal pain, gastrointestinal bleeding, and intestinal obstruction. In the gastrointestinal tract, the amyloid deposition can affect any of these layers. Mucosa becomes more friable and presents erosions. The fragility of the blood vessels with gastrointestinal bleeding risk and nerve plexuses are increased, which can alter peristalsis and decrease the compliance of the intestinal wall. CT findings are non-specific, and we should consider segmentary intestinal wall thickening as a possible presentation of systemic amyloidosis. Here are the references. I would like to especially thank Professor Luis Di Barburia and Professor Liliana Sarvente for the support for this presentation. Thank you for your attention.
Thank you, Dr. Silvera, for that presentation. Now continue with Dr. Isaac Arkelus, representando IT, with his presentation on congenital femoral deficiency.
Hi, everybody. My name is Isaac Arkelus. I'm a pediatric for orthopedic resident of State University Hospital of Haiti. I'm very happy today to talk to you about the congenital femoral deficiency, especially by using a case presentation. The congenital femoral deficiency, also known as the proximal focal femoral deficiency, is an uncommon congenital abnormality that affect the growth of the femur, resulting in a limb inequality. One person by 50,000 live births present with congenital femoral deficiency. Maternal diabetes is a risk factor. Surgical treatment can be a lengthening, a hip reconstruction. Sometimes, unfortunately, it could be an amputation. The case we have to present today is a 5-year-old female elder of a single-parent family of 2 children, unemployed mother, diabetic grandfather. She from Lagunave. Lagunave is an island of Haiti with precarious medical care and economic situation very difficult. Her mother bring her for the first time at the Adventist Hospital of Haiti in March 2021. You can see on the picture, she has an important shortening of her right leg. The right foot is very close to the left knee. On the X-ray, we see a short femur, no femoral head, a small tuft of proximal femur, a shallow of acetabulum. In May 2021, she had her surgery. We had a segment of the femur and a thigh muscle removal, but the sciatic nerve and the femoral vessel remain intact. 180 degrees of external rotation for the leg. And we make an arthrodesis of the hip joint with screw. You can see the rotation of the limb in the picture. 7 months later, she was very happy to start using her prosthesis and to start working by herself. Double victim of a precarious socioeconomic situation and of a disabled congenital deficit, she has now another chance to have autonomy of locomotion. Thank you very much for your attention. Now we are ready for your question and your suggestion. Thank you very much.
Thank you very much, Dr. Arkelus, for that presentation. We will continue with Dr. Roberto Lemus Mendez, representando a Guatemala, with his presentation on Hurling-Werner-Wanderlunge syndrome.
Hello, I am Roberto Lemus, and I will present you urinary incontinence and pelvic discomfort, not an everyday case report. The authors have nothing to disclose. A 12-year-old female patient was brought by her mother to the pediatric emergency room. The chief complaint was urinary incontinence and abdominal pelvic intense pain in the last 4 days. The patient refers that she has had smelly vaginal discharge 2 months ago. After that, 1 month ago, she started with dysuria, and therefore the mother took her to the local nurse where she prescribed antibiotics. 4 days ago, the abdominal pain got worse and it was associated to urinary incontinence, and therefore she consulted. She was the second of 2 children born by autosic delivery. The menarche was 14 months ago. She has had 1 major depressive episode 4 months ago. It was a suicidal attempt by swallowing a lot of pills that she found in her house. Her brother had acute lymphoid leukemia, and no further surgery, traumatic, or medical history was presented. She was from the suburbs in the outskirts of the metropolitan city. Her economic situation wasn't the best. Her father has lost his job recently because of the pandemic. The brother's condition didn't help to the environment. It was a very tense environment, and no psychiatric or psychological counseling was given to this family, even though the brother's condition, the economic situation, their parents were going through a divorce, and all of this environment led her to a suicidal attempt. There is a culture of antibiotic abuse practice in the undeveloped countries. This nurse that the patient was taken with wasn't a professional nurse, and she wasn't able to prescribe antibiotics. But in almost any drugstore here in Guatemala, you can find any antibiotic you like and buy it without a prescription. The systemic review, it was felt about 8 centimeters of the diameter, palpable mass in the right lower quadrant. The abdominal pelvic area was painful and tenderness in the compression, and she had reported urinary incontinence. All of the rest of the systemic review reported no signs of pathology. Blood and urinary analysis were taken, and all of them were within the normal range. A plain abdominal film showed a slight increase in the density of the pelvic cavity with no gross abnormalities associated. It was performed a complete abdominal ultrasound where it was noted the absence of the right kidney. It's worth noting that the ultrasounds here in Guatemala are performed by a radiologist or radiology resident. The left kidney was enlarged, probably compensatory because of the absence of the right kidney. And in the pelvic area, a didelphys uterus with a cystic mass that raises from the right horn of the uterus and drains into the vagina, but it doesn't drain after that. It gets collected here in the hemivagina and in the right horn of the uterus. 2 days after the first ultrasound, it was performed a control, and it turned almost completely into a simple cystic mass. All of the blood products were sedimentated, so it wasn't echogenic anymore, and it was a very simple mass. An abdominal, IV, and oral enhanced CT was performed, where it confirms the absence of the right kidney. It also confirms the presence of a didelphys uterus with a non-enhancing collection in the right horn, and this was pathognomonic of Herrlin-Bender-Wunderlich syndrome, also called OHVIRA, obstructed hemivagina associated to ipsilateral agenesis. So the classic triad to this syndrome is a didelphys uterus that is in here with a blind hemivagina and ipsilateral renal agenesis. So it can be seen in this CT that the left kidney, it was shown perfectly, and the left horn of the didelphys uterus and the left hemivagina was permeable, but it wasn't seen the right kidney, and the right hemivagina was obstructed. This is an intraoperative picture showing both horns of the didelphys uterus, where the hematometracolpos was drained, and also a repair of the didelphys uterus and the obstructed hemivagina was performed. Thank you very much.
Thank you, Dr. Lemos, for that presentation. Just the polls are now open. There should be at the bottom of the screen. They're a Zoom poll. Just remember, please, you guys can only vote one time for your favorite presentation, the one that you liked the most, you thought it was most interesting, great pictures. You can vote as you see them if there's one that particularly struck your interest, or you can wait to see all of them and then choose your favorite. Now we're gonna head on and I'm gonna pass it on to Dr. Herman Miller-Derbu, who's gonna give us a presentation on CHOP's Global Education Ventures.
Hello, everyone. My name is Herman Miller-Derbu. I'm the Global Outreach and Education Research Fellow at CHOP. And today I'll be presenting about the Global Education Ventures at Children's Hospital of Philadelphia. So first, let's meet the team. The director of the Global Outreach is Dr. Hansel Otero, and you'll see all these familiar faces. I cropped myself in there. The head of radiology department at CHOP, you can see Dr. Casadargue there, and that's Susan and Tigist. So how do we start the global education collaborations? The first step is to assess the need of the potential collaborator. And we do this by the readiness survey that we have on REDCap, where information about the facility, about the department, and training requirements is filled in. That's essentially like taking the order at the restaurant. The second step is to carve a unique curriculum or a plan based on the need, if it's educational research or teleradiology, and then based on the educational level required by that specific facility. So we start cooking. The third step is to implement. And we do this by doing didactic lectures or case reviews or CMEs, research support, and that's serving the food. The fourth step, which is the most important step, is to review, reassess, and get feedback from the facilities. What we are doing correct? Is it getting the main objective across? And this is done by the surveys that we collect on REDCap after each session or after each program that we host. Now we're going to look into some education programs we currently have going on, primarily in Africa. The first step is going to be Ethiopia. We have weekly Friday case review sessions with trainees at the Gorambasa Specialized Hospital. These Friday case review sessions happen 4 times a month. We have 2 sessions for fellows, 1 for residents, and 1 where residents present. This is a 6-month report from May to October. We have had 23 sessions so far during that time, where 13 sessions were for the fellows, 5 sessions for residents, and the other 5 sessions, the residents presented cases. We have 16 attendings participate from CHOP. 170 cases were reviewed during these sessions, 90 being neuroradiology cases, and based on modality, MRI has been top on the list. And after the sessions, we collect surveys, and these content has been reviewed as good and very good by the trainees. If you want to know more about our collaborations with Ethiopia, please visit this website, pedradethio.com. Other programs we have with Ethiopia, there's observership at CHOP, where the fellows come for 8 weeks and attach with CHOP attendings. You can see Dr. Samuel here. He was the most recent fellow to come at CHOP to do his observership. We have additional teleradiology sessions where cases can be directly sent to attendings. And for the residents, pre-COVID, we had yearly visits with didactic lectures. You can see Dr. Bahatia giving lecture here, and PACS teaching. This is Dr. Otero reviewing cases with then residents, and CME programs, of course. Next up, we have teaching softwares that we are working for upcoming residents. Next, we'll go to Botswana. At Princess Marina Hospital, we have pediatric resident lectures that are happening there currently with one lecture per month. These classes happen on Thursdays. It's a 1-hour course. We are currently on the 7th out of the 10 courses. And pediatric residents participate in these lectures. There's also a residency, radiology residency program that is up and coming in Botswana that is primarily led by Penn, and CHOP will be handling the pediatric sector of the residency. Other new projects that are starting in Malawi, Liberia, residency programs are on the verge of, are in their works, and Lesotho in Ghana to initiate and strengthen the teleradiology as well as pediatric radiology lecture supports. Thank you very much. This is my email, and that's Dr. Otero's email. Please don't hesitate to contact if you have any questions or comments. Thank you.
Thank you, Dr. Derby, for that presentation. We are going to continue to our second round of case presentations and panelists. We are going to start with Doctora Dina de Leon Gonzalez, representando a Guatemala, with her presentation on metastatic breast cancer.
Hello, my name is Dina de Leon. I'm from Guatemala and I'm radiology resident. This case shows the foregoing reality, women in rural areas, and I'm almost sure that this is a reality that we share in a lot of countries in Latin America. We have nothing to disclose and we obtained written informed patient consent for publication. The case history is about a 55-year-old female patient who for 7 years has noticed a growing lump on the left breast. She consulted the near hospital where she had radical left mastectomy and the surgical specimen was sent for histopathological study, which detected poorly differential infiltrating ductal adenocarcinoma with evidence of lymphovascular infiltration. She received only 2 cycles of chemotherapy because she couldn't pay for the other cycles. And this year she is referred to our hospital for evaluation and to continue hemato-oncologic treatment. Now we are talking about social risk factors. The patient is from the rural area of the country of Mayan origin, illiterate, of poor socioeconomic status, and with limited access to health services. She had neither access to screening mammography before diagnosis, and she wasn't educated to perform breast self-examination. She had a late diagnosis and was without medical care for approximately 2 years after the diagnosis of breast cancer. After 2 years of being diagnosed with breast cancer, she was referred to hospital and we met her. When she arrived at the hospital, we did some imaging studies. We start with chest X-ray. X-ray showed also several left pleural effusion with associated passive atelectasis. Next, we did a chest and upper abdominal CT with contrast. In these sections in lung window show multiple nodules on the right lung, predominantly in the periphery corresponding to metastases. Mediastinal window shows severe left pleural effusion with associated atelectasis and displacement of the mediastinum to the right side. In the soft tissues of the left hemithorax, there is an ill-defined hyperdense mass with irregular borders that invades skin, subcutaneous cellular tissue, and muscle. At the level of the pectoralis major and minor, extending into axillary region of the same side. Bone window shows multiple lytic lesions with irregular borders at thoracic vertebra 1 to 3 and lumbar vertebra 1 to 5, some of them with calcification inside and with infiltrative bone destruction extending towards the cortical layer, without periosteal reaction or invasion to soft tissues. In the sternum, there are lytic lesions with similar characteristics to those of the spine. Findings relate to mixed bone metastases. In this X-ray control, we see an intercostal tube is placed to resolve left pleural effusion, evidenced by X-ray and CT. After seeing the imaging studies and knowing the patient clinical history, we made a diagnosis of metastatic breast cancer in bones and lungs. We are going to talk about this diagnosis. Breast cancer is the second leading cause of cancer death in women, exceeded only by lung cancer. 5-year survival rate is largely dependent on disease stage. It is estimated that breast cancer-related deaths will increase by 43% globally from 2015 to 2030. At presentation, 4 to 10% of breast cancer are metastatic. Primary detection and diagnosis is mainly based on ultrasound and digital mammography. Imaging provides information regarding the present, extent, and distribution of metastatic disease. This is important for the patient prognosis. The most common breast cancer metastasis sites are bones, lungs, brain, and liver. In our case, we only find bones and lungs metastases. Bone is the most common site to which breast cancer metastasizes. Between 30% and 85% of patients with metastatic breast cancer will develop bone metastases. Bone metastases can present on imaging as osteolytic, osteoblastic, or mixed lesions. Breast cancer preferentially metastasizes to vertebra and pelvis, followed by rib, skull, and femur, probably because the vertebrae are highly vascularized. Lung metastases may be shown as singular or multiple pulmonary nodules, endobronchial localization, air space consolidation, lymphatic carcinomatosis. Pleural localization frequently reveals unilateral pleural effusion, which is ipsilateral to breast cancer. Thank you very much for your attention. I'm very grateful to share with you this case.
No te escuchamos, Stephanie.
Now, to prepare this presentation about rejecting the diagnosis
Sorry.
of Brenda. Hello, everyone. I am Maria.
So thank you, Dr. De Leon, for that presentation. We are going to continue with Dra. Marilia da Cruz Fagundes, representando a Brazil, with her presentation on paracoccidiomycosis.
Fagundes, a radiology resident from the Clinical Hospital of Federal University of Paraná in Brazil, and I was guided by... Hello, everyone. I am Marilia Fagundes, a radiology resident from the Clinical Hospital of Federal University of Paraná in Brazil, and I was guided by Dr. Cleberson Leitão to prepare this presentation about rejecting the diagnosis of brain metastasis. A 54-year-old man, bus driver from South Brazil, started presenting with an impatient weight loss, asthenia, and mental confusion episodes 6 months before being admitted to our service. He was a smoker and had a history of resection of a nasal squamous cell carcinoma 15 years ago.
At physical examination, he had dysarthria, right central facial palsy, and right hemiparesis. The patient had received a brain CT at his hometown, and the report described multiple hypodense lesions suspicious for metastasis. A new brain CT showed nodular lesions affecting both brain hemispheres, cerebellum, and the left nucleocapsular region, most of them with perilesional edema and peripheral contrast enhancement. A cranial MRI showed nodular heterogeneous lesions affecting both brain hemispheres, cerebellum, and the left nucleocapsular region, hypointense on T1, with areas of high and low signal on T2 and flare, and foci of hypo signal on T2 star, without diffusion restriction, but with surrounding hypersignal, suggestive of perilesional edema and peripheral contrast enhancement. The lesions presented with increased lipid peaks on proton spectroscopy, as well as low perfusion in advanced sequences analysis. That would be an atypical finding for brain metastasis, so we decided to proceed the investigation. A chest CT was performed and demonstrated bilateral, peripheral, lung nodes, and discrete tree and bud micronodes. Differential diagnoses that were thought included metastasis that was first suggested, and also infectious disease involving both brain and pulmonary parenchyma, such as tuberculosis, cryptococcosis, and aspergillosis. Epidemiological investigation discovered that the patient lived until the age of 12 in the rural area of southern Paraná, helping his family on corn and coffee plantations. A brain biopsy was conducted, and the direct mycological analysis was suggestive of paracoccidioidal mycosis. During hospitalization, he developed worsening neurological symptoms, including seizure episodes, so he repeated the MRI, showing a striking increase in the perilesional edema. The treatment was adjusted, and the patient had progressive neurological improvement and clinical stabilization. He was discharged with protocol for cerebral paracoccidioidal mycosis, steroids, and anticonvulsants, following up with infectology and neurology specialists. Paracoccidioidal mycosis is a systemic granulomatous infection caused by the fungus Paracoccidioides brasiliensis. It is an endemic disease in Brazil. Living in rural areas and agricultural activities are common risk factors. Infection is acquired by inhalation. Primarily, the lungs are affected, but the fungus may spread lymphatic or hematogenously. The chronic form of infection is the most common and may develop years after patients have left an endemic area. It predominantly affects people between 30 and 60 years with a strong male preference. Chronic infection is often subclinical, but may progress to severe pulmonary and extrapulmonary involvement, including the central nervous system, where neurologic symptoms can appear before, simultaneously, or after systemics. The main pattern of central nervous system infection is usually shown in CT as hypoattenuating lesions with surrounding edema and ring contrast enhancement. In MRI, they are heterogeneous with ring contrast enhancement and can be hypo or hyperintense on T1 and T2 with or without diffusion restriction due to the variability of the granuloma's composition. Calcifications might appear, as well as high lipid peaks on proton spectroscopy, and decreased cerebral blood volume in the perfusion image. Several patterns have been described for pulmonary infection, including small or large nodes. Imaging plays an important role in the evaluation of the infection, but the confirmation is given by biopsy, culture, or direct microscopy. Patients with early diagnosis have a favorable outcome. Clinical treatment is based on the use of antipsychotic drugs and steroids, and surgical treatment may be considered in the presence of significant mass effects. In conclusion, clinical history, including epidemiological data, are essential to guide the diagnostic reasoning in imaging analysis. Knowing the various presentations of paracoccidioidomycosis is of great importance for the radiologist. And central nervous system involvement should always be considered in patients with neurologic findings living in endemic areas.
Thank you, Doctora Da Cruz Fagundes, for that interesting presentation. Before we continue, I just want to take a moment to remind you guys that although the poll for you to vote for your best presentation is open, we still have 9 more case presentations to go, and you can only vote once. So just keep that in mind. So you may see something further down the line that you find more interesting. And without further ado, our next presenter is Doctora Angelita Su. Our next presenter is Doctora Ana Salgado, representando Argentina, with her presentation titled Congenital Syphilis with Hepatic Infarction.
Buenos días, mi nombre es Ana Belén Salgado Jaime, soy residente de tercer año de diagnóstico por imágenes de la Fundación Villavicencio de la ciudad de Rosario, Argentina. Les voy a presentar un caso de un paciente pediátrico de 42 días de edad, nacido a término de un embarazo sin complicaciones, que sufre paro cardiorrespiratorio durante el parto con internación en neonatología y recuperación sin inconvenientes. El paciente presentó ictericia que al comienzo se consideró hiperbilirrubinemia fisiológica del recién nacido. A las 2 semanas recae y agrega distensión abdominal. Es derivado a nuestro centro, ingresa con buen estado general, ictericia, distensión abdominal y hepatosplenomegalia. Como hallazgos de laboratorio presentó anemia, glóbulos blancos aumentados, hiperbilirrubinemia, predominio directa y aumento de las enzimas hepáticas. A su ingreso realizamos una ecografía donde se observa hepatomegalia, predominio lóbulo caudado, con áreas hipoecoicas bien definidas en los segmentos hepáticos 2, 3 y 4. Posteriormente realizamos una resonancia magnética con contraste, donde se observan cambios difusos en el lóbulo hepático izquierdo. Estos cambios eran hiperintensos en las secuencias ponderadas en T2, hipointensos en las secuencias ponderadas en T1. No presentaban realce luego de la administración de contraste y no provocaba efecto de masa sobre el parénquima hepático adyacente. Sí presentó restricción a las secuencias de difusión. Como diagnósticos diferenciales, por la prevalencia y edad de nuestro paciente, pensamos en tumores hepáticos primarios, como puede ser el hepatoblastoma, hemangioma hepático infantil, amartoma mesenquimático o linfoma. En procesos infecciosos, tales como hepatitis virales, toxoplasmosis, chagas o sífilis. Y también pensamos en isquemia. Realiza biopsia de ambos lóbulos hepáticos. En el lóbulo hepático derecho, se observaron cilindros hepáticos con reacción inflamatoria y signos de colestasis. En el lóbulo hepático izquierdo, se observaron hepatocitos no viables con severa distorsión estructural y necrosis en un estroma de tejido fibroso laxo similar a los llamados FOAVID o síndrome de no regeneración hepática que se suele visualizar en casos de hepatitis neonatales severas. Como diagnóstico final, tanto el paciente como su madre resultaron BDRL positivo, confirmando de esta manera el diagnóstico de sífilis congénita. La anemia se trató con transfusión de células sanguíneas, realizó tratamiento con penicilina intravenosa sin complicaciones, y finalizado el tratamiento resuelve la anemia y se normaliza la función hepática. Realizamos una resonancia magnética de control a los 90 días de finalizado el tratamiento, donde observamos atrofia residual y fisiológica del lóbulo hepático izquierdo sin ninguna otra alteración de jerarquía. Como puntos a tener en cuenta, la sífilis es una enfermedad causada por el treponema pallidum y cuando esto ocurre durante el embarazo se desarrolla sífilis congénita. La sífilis congénita puede provocar muerte fetal o neonatal, bajo peso al nacer, partos prematuros, trastornos en los recién nacidos tales como ceguera, sorderas, alteraciones neurológicas e incluso deformidades óseas. Tiene múltiples maneras de presentación, pero la mayoría de los pacientes tendrán anemia, trombopenia, ictericia, hepatomegalia y periostitis. La sífilis sigue siendo un problema de salud pública. América Latina y el Caribe constituyen la región con mayor tasa de sífilis a nivel mundial. Según la Organización Panamericana de Salud, en el año 2017 se presentaron 28.816 casos de sífilis congénitas, lo que corresponde a una tasa de incidencia de 2,1 por 1.000 nacidos vivos. El 85% del número de casos estimados de sífilis congénitas de la región correspondieron a Brasil. Dada la gravedad de esta enfermedad, consideramos que la falta de diagnóstico oportuno, como el retraso de tratamiento, aumenta el riesgo de complicaciones muy graves. Es por esto que consideramos que se debe tener en cuenta como diagnóstico diferencial en cualquier caso de afección hepática neonatal. Otro punto a tener en cuenta son los cambios en la circulación hepática que se producen tras el nacimiento. Durante la vida intrauterina, la sangre oxigenada llega a través de la vena umbilical, que se anastomosa con la vena porta izquierda, y esta última se comunica también con la vena cava inferior a través del ductus venoso. Es por este motivo que el aporte sanguíneo del lóbulo hepático izquierdo durante la vida fetal corresponde al aporte de los vasos umbilicales. Durante el periodo neonatal inmediato y tras el cierre de los vasos umbilicales, observa una caída brusca en la concentración de oxígeno a nivel del lóbulo hepático izquierdo, el cual comienza a recibir sangre de un tracto portal poco desarrollado. Por este motivo, el lóbulo hepático izquierdo involuciona de manera fisiológica respecto al derecho, y esto está facilitado también por un ductus venoso que se mantiene permeable durante las primeras horas de vida extrauterina. Para concluir, podemos hipotetizar que el hígado de nuestro paciente sufrió el daño causado por la infección sifilítica perinatal y que los cambios hemodinámicos en la circulación hepática luego del nacimiento causaron isquemia y necrosis del lóbulo hepático izquierdo. Muchas gracias por su atención.
Thank you, Doctora Salgado, for that interesting presentation. We're going to continue with Doctora Angelita Su, representing Guyana, with her presentation on ovarian dysgerminoma.
Hello, everyone. My name is Dr. Angelita Su, and I'm a radiologist from the Masters of Medicine in Diagnostic Radiology at the University of Guyana, in collaboration with Georgetown Public Hospital Corporation. My mentor is Dr. Jonathan Buchanan. I have no disclosures. Background on the case I will be presenting today. 14-year-old Sister A and 16-year-old Sister B, Indigenous sisters residing in the hinterland region of Guyana. Clinical presentation is similar for both, with gradual abdominal distension for approximately 1 year, with loss of appetite, abdominal discomfort, and pain. Villagers and family members assumed they were pregnant. Social background: isolated living miles away from the capital city in the deep rainforest along the riverbanks. Their main source of food is fish from the river and vegetable waste. Traditional medicine is customary source. Physical examination were also similar for both, with irregular, largely distended abdomen extending from the pelvis to the upper abdomen, with atrophic extremities due to poor nutrition and loss of appetite. Pertinent labs both had negative HCG tests. Ultrasound images of Sister A demonstrated multiloculated masses within the pelvis extending into the upper abdomen. Exact measurements are difficult to obtain due to the large size of the lesion, with presence of ascites in the abdomen. Contrast enhanced CT of the abdomen and pelvis of Sister A showed large multiloculated enhancing thin wall masses in the pelvis and the upper abdomen. Contrast enhanced CT of the abdomen and pelvis of Sister B also demonstrates large multiloculated enhancing thin wall mass in the pelvis and the upper abdomen. Management. Patients were advised on surgical management for high suspicion of malignancy, likely of gynecological origin. However, they declined and decided to return to their remote village to use customary traditional medicine. 1 year later, the older sister, Sister B, returned to the hospital and reported her younger sister, Sister A, had unfortunately succumbed to her illness. Bearing the same fate as her sister, she agreed to exploratory laparotomy. Pathology specimen revealed a large, solid, multilobulated mass with areas of hemorrhage, necrosis, and cystic degeneration. Pathology diagnosis reported ovarian dysgerminoma. Follow-up. Sister B presented with distension of the abdomen after surgical management and chemotherapy. Follow-up contrast enhanced CT of the abdomen and pelvis demonstrated reoccurrence of the tumor, which once again extended from the pelvis to the abdomen. Ovarian dysgerminoma originates from undifferentiated germ cells that are similar to primordial germ cells, and it is identical to testicular seminoma. It's the most common malignant germ cell tumor in childhood and adolescence, occurring in the second and third decade of life and 10% in the first decade of life. Tumor marker LDH is useful for diagnosis and post-op follow-up, with beta-HCG being rare in 5% of cases. Radiological features. Ultrasound may be seen as a septated ovarian mass with varying echotexture. Color Doppler interrogation may show prominent flow signal within the fibrovascular septum. CT calcification may be present in a speculated pattern. Characteristic imaging findings include multilobulated solid masses with prominent fibrovascular septa. Post-contrast imaging can often show enhancement of the septa. Differential diagnosis by age group. Adolescents include yolk sac tumor, immature teratoma, embryonal carcinomas, sex cord stromal tumors, gonadoblastoma. By ovarian cysts, we have serous cystoadenoma, mucinous cystoadenoma, mature cystic teratoma, serous cystoadenocarcinoma, and lastly, mucinous cystoadenocarcinoma. On my right are tumor markers that are present in associated ovarian tumors. Here is my reference. Thank you all for listening.
Thank you, Dr. Yu, for that presentation. We're going to continue with Dr. Federico Lipsich, representando Argentina, with his presentation on diastematomyelia and double aortic arch.
Buenos Aires, and this case we're presenting today is titled Complex Thoracic. Good morning, everyone. Thank you for this wonderful opportunity to share this case with you. I am Dr. Federico Lipsich, a radiology resident at the Hospital Italiano Buenos Aires, and this case we're presenting today is titled Complex Thoracic Anomalies Associated with Prenatal Thoracic Cyst. I hope you find it interesting and mainly that you like it. Our patient was born during the 32nd week of gestation. The patient's mother had undergone the usual checkups, including a prenatal ultrasound, which in turn showed a cystic mass in the posterior mediastinum. A fetal MRI was thus requested. The fetal MRI showed a cystic lesion in the posterior mediastinum causing cardiac displacement. As a consequence, a very stringent set of appointments were suggested, including the performance of a new MRI of the spine at birth. The aforementioned post-birth MRI confirmed the presence of a lateral thoracic meningocele at the level of T5, T6, and as an incidental finding, the patient presented diastematic from C6 to T4 with a fibrous septum between both hemimedullae. Diastematic is a spinal dysraphism that occurs during gastrulation. There are two types. In our case, this is a type 2, where we see both hemimedullae inside the same dural tube, separated by a fibrous septum. Our patient had vertebral malformations, although vertebral anomalies are more common in diastematic type 1. The neurosurgical team faced the possibility of a surgical approach, so a CT angiography was requested. Upon performing the requested CT angiography, we were surprised to find two dorsal aortas merging from the infradiaphragmatic level. A double aortic arc with an atretic left arc and the left subclavian artery arising from the left dorsal aorta. To summarize the findings of the malformative sequence of our patient, we prepared the following chart in which we see the double aortic arc with the left atretic arc. Following Stewart's classification, it will be classified as a group 1, subgroup B3. In our patient, the left subclavian artery arises from the left dorsal aorta, right here. The embryogenetic deviation is developed during the 3rd week of embryogenesis, when very briefly, two dorsal aortas and two ventral aortas are joined by 6 pairs of arcs. The first 2 arcs involute, while the third one forms the neck vessels. The fourth forms a definite aortic arc, and the right fourth arc usually regresses. Finally, the 5th arc regresses, and the 6th arc forms the ductus arteriosus and the pulmonary arteries. In this case, we see the double aortic arc is incomplete due to the atresia of the left arc. And here we show the left dorsal aorta that is persistent. Here we can see the lateral thoracic meningocele, which is an herniation of the dural sac with CSF inside that projects through a paraspinal defect. Here we see the CT. Our case was extremely challenging for us to diagnose a non-previously reported complex malformative sequence. We feel it is important to emphasize the role of both fetal and postnatal imaging in deciphering the pathology and essentially helping the patient. Thank you very much for your attention.
Thank you very much for that presentation, Dr. Lipsick. We are going on with our last presentation for this session. We have still a couple more to go. Dr. Gerardo Llamas Linares, representando a Mexico, with his presentation titled Diaphragmatic Hernia with Pulmonary Sequestration.
Hello, I'm Dr. Gerardo Llamas Linares, and I'm going to present the case diaphragmatic hernia with pulmonary sequestration from our institution, Centro Universitario de Imagen Diagnóstica Hospital Universitario, José Eleuterio González in Monterrey, Nuevo León, Mexico. With thanks to my team, and special thanks to my mentor, Dr. Claudia Yazbek Rodriguez Garza from Pediatric Radiology. Our case begins with our patient's mom, who is a 32-year-old female on her 3rd pregnancy, with clinical history of gestational diabetes, with none other relevant personal pathological or non-pathological data. On her routine checkup by obstetric ultrasound, it was found an anechoic lesion at the left lung base, suggesting at the time a diaphragmatic hernia, for which a fetal MRI was suggested for further evaluation. Upon her arrival to our center, we did a fetal MRI, in which, in the posterior medial region of the left hemidiaphragm, we can see a continuity defect that measures around 15 by 15 millimeters and conditions the passing of the gastric fundus into the left hemithorax, which suggests a diaphragmatic hernia. At the time, the pulmonary volume was found to be normal, and so the pregnancy was decided to continue normally until maturity. On the next image on another coronal plane, we can continue to corroborate the diagnosis. On the sagittal images, we can see the diaphragmatic hernia allowing the passing of the gastric fundus, and which corroborates with the actual images. On gestational week 40.4, our patient was received by C-section due to previous C-sections of the mother without any obstetric complications. It will receive a baby boy with an Apgar scale of 8 and then 9, with a weight of 3.6 kilograms and length of 50 centimeters. The patient, due to his prenatal diagnosis, was admitted to the neonatal intensive care unit with a normal physical exam. Subsequent studies were made to our patient, including like this neonatal X-ray, which had relevant findings at the lungs, which showed diffuse and bilateral increase of its opacity with none other relevant findings. On subsequent X-rays, the lungs cleared and everything else looked normal. For the evaluation of the prenatal diagnosis, a fluoroscopic evaluation of the upper GI tract was made, which showed an adequate passing of the contrast material through the oral cavity and pharynx, a normal cardioesophageal joint with passing of contrast into the gastric chamber with adequate motility. On its posterior region, in the gastric fundus was found to be extending into the left hemithorax through the diaphragm, which corroborates the prenatal diagnosis of a left diaphragmatic hernia. So the patient was programmed for surgery. At first, a thoracoscopy was made, in which they found a spleen-like mass adjacent to the major gastric curvature, for which they decided to do a lateral thoracotomy for the complete removal of this mass, which had to be dissected from the stomach, and the posterior reduction of the gastric fundus into the abdominal cavity with primary closure of the diaphragmatic defect. So this surgical piece was decided to be sent to pathology, and pathology reported back a pulmonary segment that weighed in 10 grams and measured 4.5 by 3 by 1.8 centimeters with adherent pleura, for a final diagnosis of an extrapulmonary sequestration in a diaphragmatic hernia. The patient had satisfactory evolution and was discharged after an uneventful recovery, which we can see in this post-op X-ray, which had no relevant findings. For the review of this case, we had a patient with a pulmonary sequestration coexisting with a congenital diaphragmatic hernia. A pulmonary sequestration is a segment of the lung that has no identifiable communication with normal bronchi 3 and receives blood from a supply that's independent and is from the systemic arteries. Its exact incidence is undetermined, but review studies can estimate an incidence of 0.15 to 1.8% of patients. And congenital diaphragmatic hernia is a malformation characterized by a diaphragmatic defect that results in the herniation of abdominal organs into the thoracic cavity during the development. Reports of its prevalence range between 0.7 and 15.9 out of 10,000 birds. There are a few cases reported in literature of coexisting diaphragmatic hernia and pulmonary sequestration. And recognizing that there is an association between these two phenomena can permit the resection of the extralobar sequestration at the same time of the diaphragmatic repair and improve the treatment of our patients. Retrospective analysis of our images showed that there was an image close to the major gastric curvature that might have been the pulmonary sequestration seen at the surgical repair. Nonetheless, it wasn't seen at first, for which of the importance of recognizing the association of the coexisting entities for the better of treatment of our patients. Thank you so much for the opportunity and have a nice day.
Thank you, Dr. Llamas Linares, for that presentation. Before we continue with our case presentations, I'm going to leave you with Dr. Otero, who's going to give us a quick presentation on SLAB research and academic publishing.
All right. Buenos dias. Good morning, everybody. So I just wanted to spend 2 minutes, we're gonna get this out of the way. 2 minutes telling you about a new program that a new series of webinars that we're launching and that I think that you should know about. So in collaboration between the World Federation of Pediatric Imaging and the Sociedad Latinoamericana de Radiología Pediátrica, we are doing a short course on Introduction to Research and Academic Publishing in Pediatric Radiology. The idea has been brewing for a while in this editorial comment from Dr. Ugas, Fasecas, and Lipsik that was published in the Journal of Pediatric Radiology last year. They talk about how are we going to grow as a society, and in particular for the Society of Pediatric Radiology. And one of the pillars of growth for the near future is to start a program to support Latin American authors. We are supposed to help develop skills in scientific writing and English editing. And the idea is to close the gap or eliminate that language barrier in whatever way we can. There is a survey ongoing on what are the needs for supporting research, and I'm going to post the same link in the chat immediately after this presentation. And we would love to have residents involved, particularly if you are a resident that is interested in pediatric radiology. That, judging for the amount of cases that we receive that are with pediatric patients, it looks like it could fit any or a majority of you. At the end, when you talk about what is needed and what are the main barriers, everything boils down, or the two main problems for any new academic enterprise is time and money. Unfortunately, I don't have either one. Like, I cannot provide you with more time, nor with more funds to produce research or to participate in publishing. However, what we can do is provide mentorship and improve the quality of the already ongoing research in the region. And also what we can do is help you be more efficient with your time and your money. So by creating an environment of increased efficiency, we will be utilizing those finite resources in a better way. So what we came up with was, again, a series of webinars that is a brief introduction to research. And I want you to separate both and look at the title carefully. One is research, investigación. We all know what that means. You know, you have your subjects, you have your data analysis, and you have publication as part of it. However, the second component is academic publishing, because it so happened that participating and being part of that community of publishing authors is not necessarily related to the type of research that you're doing. It needs to be part of our day-to-day practice. It needs to be part of our way of communication and our way of spreading guidelines and for how we practice. So we're gonna provide these webinars, or we're gonna run these webinars to provide guidance into study design, data collection, data analysis, and manuscript preparation. It's targeted for members of the Pediatric Radiology Society. However, trainees are also more than welcome to participate. And the idea is to increase the chances of publication in pediatric radiology and other peer-reviewed publications. it aligns really well with what we're doing here today, where the best cases we're going to help them get published as well. So these are the 3 sessions that we have planned. There is a session on March 3rd in the evening. Again, the hours are East Coast time, New York time. And the first session is on basics of clinical research and how to start a project. Then a second session that is more like how to do a literature search and how to actually write. Writing in English is very different than writing scientific English is very different than writing prose in Spanish. Nobody wants here to graduate the next Ernesto Sabato, or I don't know, or Borges. No, we're talking here about basic writing skills that you can boil down to a formula, so you can participate and you can publish your results without much delay. And then the third session is a session that to me is very, very interesting because it's a perspective of the reviewer and the perspective of the editor. Like, okay, you have a project, you write it. Now what happens? What happens behind the scenes? Like what is the editor gonna base his decision or her decision in publishing or not your project? So these are the sessions. The registration link will be sent out after the survey is completed. And I just invite you all to participate. I think it's going to be these are going to be very useful sessions, regardless of where you are in your academic career. And it will encourage people to, again, to be more efficient with their time and be better academicians. Thank you very much.
Thank you, Dr. Otero. If anyone has any questions for him, feel free to put them in the chat and we'll monitor and answer those appropriately. We're going to continue to our last 5 cases or 5 case presentations for today. Our next presenter is Doctora María Florencia Conde, representando Argentina, with her presentation titled Esophagitis from Impacted Foreign Body.
Hello everyone, my name is Florencia Conde. I'm from Argentina and I'm a radiology resident at Hospital Italiano de Buenos Aires. First, I'd like to express my special thanks to my mentor, Roy Lopez Grove, and collaborators Germán Lopez and Julia Seidman for helping me with this presentation, and my gratitude to the organizing committee for letting us participate in this competition. I have no relevant disclosures, so let's start with our case. It's about an 18-month-old female patient with no personal nor family history. She was on no medication, so a previously healthy little girl. She presented with an acute onset of poor appetite, dysphagia to solid food, cough, and isolated fever episodes in the last 2 months. The family stated that the symptoms began after eating some French fries at a social event. The laboratory showed no relevant findings. Initially, an esophagram with barium was performed, which showed a circumferential and irregular narrowing at the junction of the upper and middle third of the esophagus, associated with mild proximal dilation and persistence of contrast material in the upper esophagus, with no other relevant findings. To further investigate the underlying cause of this esophageal abnormality, a pneumocomputed tomography was performed. Pneumo-CT is a technique frequently used in our institution for gastroesophageal tumor staging in adults, among other indications, and consists of sustained administration of carbon dioxide through a transnasal Foley catheter placed below the cricopharyngeal muscles during the acquisition of the CT by means of an injection pump at a regulated pressure in order to achieve an optimal distension of the esophagus. This technique allows a more precise identification of esophageal wall lesions, their morphology, limits, and relationships with adjacent structures. In this case, we see 2 coronal views with lung window in B and mediastinum window in C that show an irregular narrowing of a short segment of the esophagus between the upper and middle thirds, just as in the esophagram, and revealed that this narrowing was due to a circumferential mural thickening of the esophagus. Images A to D are axial views of the pneumo-CT. Arrow in A shows the esophageal mural thickening that reached 10 millimeters of maximum thickness. Thick content in lumen, as indicated by arrow in B. Diffuse alteration of the adjacent fat, pointed out with arrowheads in A, B, and C. And slightly enlarged periesophageal and mediastinal reactive lymph nodes marked in D. Image E is a three-dimensional reconstruction with long window setting that shows the area of narrowing. And the last image is a 3D volume rendering reconstruction of the study. Pneumo-CT allowed to rule out some differential diagnoses that include extrinsic compression from mediastinal masses, such as large lymphadenopathies. Vascular rings and pulmonary slings were also easily excluded since there were no normal vessels surrounding the esophagus. It also put away the possibility of a neoplastic esophageal origin, such as leiomyomas. These rarely occur in the pediatric population. They present as smooth surfaced masses, occasionally with a circumferential growth pattern, but they are found predominantly in the middle and lower thirds of the esophagus, and they contain areas of calcification. Finally, the findings of pneumo-CT previously mentioned, the irregular narrowing of the lumen in the upper and mid thirds, the circumferential mural thickening, the alteration of surrounding fat, and the reactive lymph nodes oriented the diagnosis toward benign pathology of inflammatory origin, such as esophagitis. That could be linked to a foreign body given the clinical history of our patient. An upper gastrointestinal endoscopy was performed. They found food debris in the esophagus, a foreign body that was embedded in the esophageal wall, and mucosal edema. The foreign body was extracted without complications, and these findings confirmed the diagnosis, which was an esophagitis from an impacted foreign body. The patient received antibiotics therapy and corticosteroids. She improved with this treatment and was discharged after 24 hours. So that'll be all. Thank you very much for your attention. I hope you enjoyed it as much as I did. Saludos desde Argentina.
Gracias, Doctora Florencia Conde, for that interesting presentation. Our next presenter is Dr. Facundo Ferrari, representando Argentina, with his presentation on progressive osseous heteroplasia.
Hello, thank you for having me. It's an honor to be here. My name is Facundo Ferrari. I'm a third-year resident in pediatric radiology at Garrahan Hospital in Buenos Aires, Argentina. And I want to share with you a case report about the progressive osseous heteroplasia. The objectives are: report a female patient with progressive ossification of the soft tissue involving her left leg, describe the imaging finding of this disease, and recognize differential diagnosis. We do not have any disclosure. So, the clinical case is about a 2-year-old female twin, bichorionic, low birth weight, whose mother noticed an indurate nodular tumor with progressive growth in her left lower limb, affecting from pelvis to foot. Diagnostic tests were performed. First, blood tests show an increase in alkaline phosphatase. And what about the X-ray? But let's see. On the left side, we have an AP radiograph of both legs at 5 months old, where we can observe calcification of the soft tissue at the left knee. Then another X-ray at 15 and at 21 months, where progression of this calcification is observed, involving to knee and hip ankylosis. Additional X-rays were also performed to exclude another abnormalities. The only finding was a bilateral clinodactyly of the 5th finger. Well, an MRI was performed in order to evaluate soft tissue involvement. We can see extensive signal alteration in the muscle and dermis with hypointense signal corresponding to heterotopic calcification. And the same, but in a coronal view. So let's talk about the progressive osseous heteroplasia. It's a congenital disorder characterized by dermal ossification during the infancy, with progressive heterotopic ossification of cutaneous, subcutaneous, and deep connective tissues. It has an asymmetric mosaic distribution and predominance of intramembranous rather than endochondral ossification. No other congenital malformations are associated. Apart from the physical exam, some diagnostic tests should be performed. X-ray will show an ectopic calcification of fibrillar appearance, and generally, the serum blood tests are normal, but sometimes the alkaline phosphatase can be high. Regarding the management, there is no effective treatment, and it evolves to a complete ankylosis. All right, now some key points of this disease. Generally, calcification starts the skin and progresses into deep layer. The appearance of cocoon-like web is described in the X-ray. The usual course is joint ankylosis. A delay in affected limb ossification is also described. It's important to notice that no other skeletal malformation are associated. POH could be misdiagnosed as fibrodysplasia ossificans progressiva or outright hereditary osteodystrophy because they share some clinical and radiological factors which will be described in the next slide. The three characteristics will approximate the diagnosis of POH, while the presence of any of these will help us roll it out. The presence of normal endocrine function and the absence of a typical abscess associated can distinguish POH from AHO. Well, now some examples of both differential diagnoses. In FOP, the typical findings are the deep soft tissue ossification affecting, in this case, the axilla and the hallux malformation, whereas in AHO, we could see brachydactyly and ossifications tend to affect superficial layers. Finally, progressive osteoheteroplasia is a rare disease. However, it should be included as a differential diagnosis in a pediatric patient presenting with heterotopic calcification. Well, that's all. Thank you for your kind attention. Bye-bye.
Gracias, Dr. Ferrari, for that presentation. Our next presenter is going to be Doctora Laura Ayala, representando Guatemala, with her presentation on angiostrongyliosis.
Hi, I am Laura Ayala, resident of Radiology, Guatemalan Institute of Social Security. Thank you very much for the opportunity to present this interesting case. Clinical history. 52-year-old male Latin patient present to the ER with a supraumbilical mass of 5 months of evolution. He says that the mass has increased inside over the course of evolution. No pain, no fever, chills, no change in bowel habits with no previous treatment. Physical exam. Febrile, vital sign within normal limits. Abdominal exam. Palpable mass in the supraumbilical region, injured with defined aids, not painful on palpation, not reducible. Lab tests showed normal parameters. Imaging studies. Abdominal ultrasound. Large heterogeneous mass located in the subcutaneous soft tissues, infiltrating the muscle and mentum. Echogenic adipose tissue in the center, anechoic areas that could represent necrosis. Low flow the cell identified with Doppler. Imaging studies, abdominal CT. large-sized heterogeneous mass located in the subcutaneous soft tissues infiltrate muscle and momentum, low density in the center that correspond to the fat and necrosis, no increase in density with intravenous contrast. Origin of the mass comes from the transverse column, no signs of obstruction. Large-sized heterogeneous mass located in the subcutaneous soft tissues infiltrating muscle and momentum. Low density in the center that correspond to fat and necrosis. Diagnosis and treatment. Neoplastic process at the level of the transverse column were considered likely adenocarcinoma. The patient was taken to the operating room as a neoplastic process is suspected, where an stent right hemicolectomy extending to the transverse column was performed. Pathology. The pathology report labs of antiostrongylus costaricensis. Relevant medical and social history. A patient originally from Guatemala City works as a church minister where he carries out activities in the country, traveling constantly where he visits villages and lives with the communities. Angiostrongylosis abdominal. The nematoangiostrongylos costaricensis is the causal agent of abdominal angiostrongylos intestinal. The main definitive host for a costaricensis is the hispid corn rat. Distribution of the costaricensis in Central America and in South America. Thank you for your attention.
For that presentation, Dr. Ayala. Our next presenter is Dr. Santiago Osorio del Rio, representing Mexico, with his presentation on vertebral giant cell tumor.
Buenos días, mi nombre es Santiago de Jesús Osorio del Río. Soy médico colombiano, residente de radiología e imagen diagnóstica y terapéutica en el Hospital Regional ISSSTE de Monterrey, en Nuevo León, México. El nombre de mi presentación es tumor de células gigantes en cuerpo vertebral de un paciente pediátrico diagnosticado por resonancia magnética. Mi maestro asesor fue el doctor Samuel Iván Espinosa Tristán, radiólogo pediatra adscrito a dicha institución. En cuanto al caso clínico, se trata de una paciente femenina de 16 años de edad, cuyo único antecedente relevante es que fue producto de un embarazo gemelar disigótico por inseminación artificial. Ella tuvo una presentación clínica insidiosa de aproximadamente 6 semanas de evolución, en la cual presentó parestesias y disminución de la fuerza muscular en las 4 extremidades, de predominio en las extremidades inferiores, lo cual llegó hasta la limitación a la marcha, por lo cual deciden consultar. El médico que le realiza la valoración inicial, el pediatra, decide solicitar una resonancia magnética contrastada de segmento cervical y dorsal para descartar una lesión intramedular, por lo cual es referida a nuestra institución para la realización de los estudios y para continuar el manejo interdisciplinario. En esta diapositiva vemos 4 imágenes de resonancia magnética, todas en adquisición sagital. Vemos en la imagen A, que es una secuencia de T1, cómo se observa una imagen ocupante predominantemente hacia los elementos posteriores del cuerpo vertebral de T2, en la cual se observan algunas cavidades con niveles líquido-líquido en su interior, y se observa cómo se expande hacia los tejidos blandos adyacentes a la lesión. Llama la atención lo que señala la flecha amarilla, y es que dentro de estas cavidades con niveles líquido-líquido hay zonas hiperintensas, lo cual pueden corresponder con restos hemáticos. La imagen B corresponde a una secuencia de T2, donde vemos la naturaleza multicavitada de esta lesión y cómo afecta también el tercio posterior del cuerpo vertebral de T2. En la imagen C vemos, es una secuencia de STIR, vemos nuevamente la presencia de estas lesiones cavitadas, que es lo que señala la cabeza de flecha, y la imagen D corresponde con un T1 contrastado con saturación grasa, en la cual vemos cómo hay realce de la porción sólida de dicha tumoración. Se destaca también la estrechez del canal medular a este nivel en todas las secuencias, lo cual explica los síntomas que presentaba la paciente. Posteriormente se realizó una tomografía en la cual se confirma la naturaleza lítica de la lesión. Vemos en la imagen A, en un corte coronal, cómo se observa una lesión puramente lítica, predominantemente hacia la derecha del cuerpo vertebral. En la adquisición sagital de la imagen B, vemos cómo afecta el tercio posterior del cuerpo vertebral y cómo afecta también los elementos posteriores, que es lo que podemos ver en la imagen C, donde vemos su naturaleza lítica y su reconstrucción tridimensional con la ausencia de los elementos posteriores a este nivel. Los diagnósticos diferenciales por imagen fueron los de un plasmocitoma, un osteoblastoma o un hemangioma. Sin embargo, el servicio de neurocirugía decide realizar una resección en bloque de la lesión, el cual este producto pues se envió al laboratorio de patología con el resultado de un tumor de células gigantes con quiste óseo aneurismático asociado. Este mismo servicio realiza 2 procedimientos más intentando hacer resección completa de la lesión. Sin embargo, debido a la localización, no se logró la excisión completa de la misma. Esta es una resonancia postquirúrgica en la cual vemos cómo hay persistencia, que es lo que señala la cabeza de flecha amarilla, cómo hay persistencia de la tumoración hacia el cuerpo vertebral y hacia sus elementos posteriores, y la flecha señala una colección postquirúrgica asociada. Datos interesantes de nuestro caso, principalmente la epidemiología. El tumor de células gigantes es un tumor que se da principalmente en esqueletos maduros, personas por encima de los 20 años. En nuestro caso se presentó en una femenina de 16 años. Típicamente está localizada en las epífisis de huesos largos, en su mayoría de los casos en los huesos largos alrededor de la rodilla, tibia proximal y fémur distal. En nuestro caso se localizó en un hueso plano, que fue la vértebra de T2. Cuando afectan la espina dorsal, principalmente afectan el sacro. La clínica típica es de dolor y limitación funcional articular, dependiendo del segmento que estén afectando. En nuestro caso, debutó con un déficit neurológico como síntoma principal. El diagnóstico generalmente se hace por radiografía simple. En nuestro caso, se diagnosticó por resonancia magnética. Y este puede asociarse a quiste óseo aneurismático en una minoría de los casos, que fue pues, precisamente nuestra situación. Vemos en las imágenes inferiores cómo es la imagen típica de un tumor de células gigantes, como una lesión lítica excéntrica, y sus imágenes correspondientes por tomografía y por resonancia, y la comparación con nuestro caso, que tiene una apariencia atípica y una localización atípica. El tratamiento, generalmente se prefiere la resección en bloque y el curetaje óseo. Sin embargo, para las lesiones de difícil alcance como esta, se prefiere el denosumab, que es un inhibidor del receptor activador RANKL, que inhibe la diferenciación y activación de células gigantes similares a osteoclastos, por lo cual disminuye esta actividad lítica y crece nuevo hueso. En nuestro caso se recurrió a la resección quirúrgica como terapia inicial, probablemente por los síntomas neurológicos y el compromiso medular asociado. Sin embargo, no se logró la resección completa de la lesión. Posteriormente, el pediatra sugiere continuar con radioterapia, con lo que presentó mejoría de los síntomas. Les agradezco por su atención, agradezco a los demás colegas que van a presentar sus casos, a mi maestro y a los jurados que van a evaluar estas diapositivas.
Gracias, Dr. Osorio del Rio, for that presentation. Our next and final presenter would be Doctora Valentina Torello, representando Uruguay, with her presentation on hepatic hydatitis migrated to the thorax.
Soy Valentina Torello, residente de segundo año de imagenología del Hospital de Clínicas de Uruguay, y voy a presentar un caso de quiste hidático hepático transitado al tórax. Es un paciente de sexo masculino de 65 años que trabaja en el sector rural, que consultó por tos y expectoración, que se acompañaba de dolor tipo puntada de helado en hemitórax derecho de 1 mes de evolución y que en la última semana agregó disnea ante mínimos esfuerzos. El examen físico se destacaba que a nivel pleuropulmonar presentaba un murmullo alveolo vesicular bilateral y sin estertores. Entonces al paciente se le solicitó para clínica sanguínea, de la cual se destacaba una leve leucocitosis a predominio de un aumento de los eosinófilos, y también se le solicitó una radiografía de tórax. Este es el frente y el perfil donde se destaca que a nivel basal derecho presentaba esta opacidad que era como discretamente redondeada, presentaba un límite superior que era bien delimitado, pero que el límite inferior no se identificaba con claridad, presentando un signo de la silueta con el hemidiafragma derecho. Y frente a estos hallazgos, que se interpretaron como una masa pulmonar, se le realizó una tomografía de tórax y abdomen en fase portal. Estas son imágenes en el plano axial de cefálico a más caudal, donde se identificaba a nivel de los segmentos hepáticos 7 y 8 esta formación de aspecto quístico que era polilobulada con una pared gruesa que presentaba algunas calcificaciones. Su contenido era heterogéneo con estas vesículas hijas en su interior que se señalan con la flecha celeste, que son como pequeñas imágenes redondeadas de menor densidad que el resto del contenido del quiste. En el plano coronal se puede apreciar mejor cómo la lesión se extiende superiormente hacia el tórax, atravesando el diafragma y comprometiendo hacia la práctica totalidad del lóbulo inferior derecho. También se identificaba otra lesión hipodensa señalada con la flecha amarilla, que presentaba también una pared gruesa, pero que impresionaba encontrarse completamente por encima del diafragma. Entonces, estos hallazgos orientan a un quiste hidático transitado al tórax, que por la presencia de estas vesículas hijas en su interior corresponde a un quiste hidático tipo 2, según la clasificación de la OMS, lo cual indica que se encuentra en un estado activo o que el quiste es fértil. Para valorar la presencia de una relación con la vía biliar, se le solicitó una colangioresonancia donde se identificaba a esta lesión quística compleja con una pared hipointensa y gruesa en secuencias T2 y a las vesículas hijas en su interior hiperintensas, hallazgos que son característicos del quiste hidático, que si bien se encontraba en íntimo contacto con un canalículo biliar, no se identificaba dilatación de la vía biliar ni imágenes patológicas a nivel del colédoco. Por lo tanto, se descartó una apertura a la vía biliar. Al paciente se le realizó un tratamiento quirúrgico que consiste en la resección parcial del quiste junto con una resección atípica del lóbulo inferior, pero previo a la cirugía se le realiza tratamiento con un antiparasitario vía oral, el albendazol, con el objetivo en realidad de minimizar el riesgo de hidatidosis secundaria en caso de que haya una contaminación durante la cirugía. La anatomía patológica confirmó el diagnóstico de una hidatidosis hepática y pulmonar con elementos parasitarios que eran viables. El paciente tuvo una buena evolución posquirúrgica. Esta es la tomografía de control al año de la cirugía, donde se identificaban los cambios posquirúrgicos a nivel del hemitórax derecho y a nivel del hígado, pero sin evidencia de una recidiva local a nivel del sitio quirúrgico señalados acá. Entonces, a modo de resumen, la hidatidosis es una ciclozoonosis que va a estar producida por el cesto equinococo granuloso. Este es un esquema del ciclo de vida del parásito, donde es importante recordar que los humanos, nosotros somos huéspedes intermediarios accidentales al ingerir alimentos que van a estar contaminados con los huevos eliminados por el huésped definitivo, que generalmente es el perro. La localización más frecuente del quiste hidático es el hígado, pero saber que se lo puede llegar a encontrar en cualquier otro órgano. La OMS creó una clasificación de 5 tipos de quistes hidáticos, cada uno de ellos con hallazgos característicos en la imagen, y esta clasificación en realidad lo que nos permite es dividirlos en quistes que son activos o quistes fértiles en un estado transicional o ya en quistes inactivos. La hidatidosis transdiafragmática es la complicación que presentó el paciente, que se suele dar en quistes que van a estar localizados a nivel del domo hepático, quienes por su cercanía y contacto con el diafragma lo comprometen y secundariamente ascienden hacia el tórax. Este tránsito puede ser abierto cuando hay apertura del quiste hidático al árbol bronquial, que se puede o no estar también acompañado de una apertura a la vía biliar. Entonces, En conclusión, saber que los diferentes métodos de imagen no solo permiten llegar al diagnóstico del quiste hidático, sino también son esenciales para determinar su localización, estadio o sus posibles complicaciones. Esta es la bibliografía consultada. Muchas gracias.
Muchas gracias, Doctora Torello, for that presentation. This concludes all our case presentations for this event. We want to take a moment to thank all the presenters for their hard work putting all these PowerPoints and these presentations together, as well as all the mentors for guiding their trainees through this process. We're going to take a break so the judges can see the presentations, deliberate, and do the poll. So you have a couple of minutes to put in your final poll of your best presentation, the presentation you like the most, before we close the poll. So take a moment and make sure you put your vote in, and we'll be back with the winner announcements shortly. The judges have deliberated. I know everyone made great presentations and they all put hard work, but we're about to reveal final decisions. So we are going to start with the third place for best presentation, which is the winner of a $250. The winner is from Argentina, Dr. Federico Lipschik, with his presentation on diastemalia and double aortic arch. So congratulations, Dr. Lipschik and his team. All righty, second place is gonna be also from Argentina, Dr. Facundo Ferrari with his presentation on progressive osseous heteroplasia. So congratulations to Dr. Ferrari and his team. And our first place winner, you're supposed to do a drum roll, Dr. You want to do the people's choice first? People's choice first? Okay, sorry. The people's choice based on the poll is from Peru, Dr. Alice Arela Kipse with her presentation on spinal trauma with congenital anomaly. Okay, so drum roll now. So for first place from Brazil, Dra. Débora Otto with her case for renal tuberculosis. Congratulations to Dra. Otto and her team.
And, yeah.
Thank everybody again for coming, for spending Saturday with us. And I'm gonna pass it on to Dr. Otero for his closing remarks. We're just rolling around.
Yeah, sure. What are you gonna say?
It's already, the microphone is open, and so whatever you're gonna say, you should start.
All right, this has been a lot of fun. Unfortunately, everybody couldn't win, but everyone is a winner. All the cases were great. This was tough. We had a hard job, but thankfully we had seasoned radiologists like Hansel over here to provide guidance.
First of all, I really want to thank everyone that participated. We know it's a lot of work. We know it's hard from the get-go, from choosing your best case to trying to explain it, and extra work of putting in a presentation, turning in the video, and all those things. So we appreciate that. We appreciate the effort that many made to make presentations in English, so even more of us can understand the case. We want to really thank all people that help us spread word. We haven't designed a good way yet of how to invite people for this event. So it's been kind of an uphill battle of like, how do you get to all the residents in a region? Residences that are not under a single institutional, I don't know, a structure. And so please help us getting the word out. This is a good point to invite you to the next session. So our next session is going to be centered in Asia and the Middle East, and then we'll go back to Africa, and next year around February we'll see each other again. Okay, so keep this in mind. I hope that you I hope that you enjoy as much as we did. Seeing residents presenting is kind of a favorite for me, and I really enjoyed the entire the entire process, let's say. So we hope that this make you a better resident or a smarter radiologist.
Yes. Yes, we really want to thank everybody. So many people are involved in, in this process, from the folks in the room, Herman, who's in the background, just making things happen, to our host, our bosses, Casa Darge, McShaw, people providing funding, our colleagues who are very supportive, Katie Fine with the website, our colleagues in the Center for Global Health, Megan, Alejo. There's really a lot of people involved, and this is something that we just started doing a few months ago, from a conversation at dinner to this. So it's really great to see how this has evolved. So again, keep encouraging yourselves, residents, definitely network, and feel free to reach out to us at any time.
Yeah, and again, the overarching goal is that the winners, we will push them towards publishing these cases and getting them into the literature. And yeah, thank you all for participating. Thank you, Silvina. That was got us right, like a right start with a great talk. And anyway, see you all soon.
Fill out the evaluation form in the link if you're still here and listening.
Oh yeah, we need those evaluations. Thanks.
Bye.